Hi, this is Elliot Fishman, and welcome to our Facebook Live. I think today is around the 23rd of January, and hopefully the weather is good by you, as it is by us. Just a couple things. One is to see I have my Lust Garden badge on, and you saw on Facebook yesterday that we congratulated the Lust Garden Foundation, and particularly Bert Vogelstein, his lab was dedicated as the fourth Lust Garden Research Lab, and which is a major honor. Remember, the Lust Garden is also the folks who, as part of Bert's lab, fund us for the Felix Project. So that's really exciting, and they agreed to fund us for another year, which is particularly exciting. And that HOPE project on pancreatic cancer is really going well, I think, and we look forward to doing great things over the coming year. So that's very exciting, and we really thank Lust Garden for helping us. A second thing is, some of you last week in disdain was sure that Kansas City was going to win, and I told you that New England surely was going to win, and I said 31-27. And in fact, it was 31-28 till about 20 seconds to go. You know, Kansas City got a field goal, and then, of course, yada, 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 the Patriots won. So I told you they won. I had my official Patriots hat on last week, which I have on now as well. So I will tell you that Super Bowl, it's not this weekend, but it's in 2 weeks against the Los Angeles Rams, which used to be, I think, the St. Louis something or other. So I'll say 27-21, New England easily beating those people. So it should be a great game, nevertheless. What else? So this week I picked kidneys, and I just thought I'd do hot topics. I am preparing a talk that a lot of the stuff you'll see will appear in more detail in the talk, because with Facebook Live, this week we're not going to show any slides. So I'll be talking about things. And I thought there were really 4 articles I read, and the notes from the articles actually, I think there's like 30 pearls. They'll be in CTisus February edition. And again, as I said, there'll be a lecture on this topic, probably, I'm looking at the schedule in the back here, probably in early March. So there's one article by Corwin was looking at a question that we've commonly brought up as well is there a chance that you could mistake a papillary renal cell carcinoma and simply call it a cyst? And, you know, the problem with papillary renal cell carcinomas, they're not very vascular. That's one thing. But they're also homogeneous. That's another thing. And they're low density, you know, they enhance as much as 70, but on non-contrast, they may be like 30. Remember, we said 37 is the magic number with the average density of a carcinoma. The question always comes up is, what is it that is a magic number? Is there a number beneath which, on a non-contrast scan, you don't really need to worry that that lesion is a malignancy? And typically, we like to say under 20 and over 70 are non-contrast. So in this article, they made the point that if a lesion looks homogeneous, but it measures less than 20 non-contrast or less than 30 on portal phase, then you basically can call it a high-density cyst, and it's not going to be a tumor. Now, they went through a lot of different data, and I won't share all of that data with you. I'm looking at it right now. They did mention that they had 2 cases where the lesions were homogeneous and they only enhanced a little bit. So they made the point that potentially in maybe 1% of cases, at least that's what it was by them, 2 out of 107, where perhaps you could mistake something as a high-density cyst and it's really a tumor. Remember this balancing act, 25% of tumors under 2 centimeters that are resected are benign. So we don't want to be operating on patients who have simple cysts, right? You know, that's what happens. So you need to have some sort of rules. And I think that under 20 is a really good rule. That under 30 is probably a fair rule as well. And again, you know, there is a chance, probably 1%, that you could make a mistake. And so here's a quote. Of those with unenhanced face imaging, 3 of 107, or 2.8%, were both homogeneous and were less than 20 Hounsfield units in attenuation. So the thing they wanted to say is that sometimes you theoretically could get a small papillary renal cell that just is very low density. Now, I guess the good news is if you have a papillary that's not very vascular, then it's probably going to be a benign in terms of its what happens to it over time. Remember, we follow a lot of patients with comorbidities, and even without comorbidities, with small tumors, because you think that papillary, the chance of them metastasizing is very low, and then everything's a risk reward. So it's that conversation. And I'll give you another quote from the article. An incidental renal mass is considered to be a benign cyst if it is homogeneous in less than 20 Hounsfield units, and is considered indeterminate if it measures above 20 Hounsfield units on either unenhanced or contrast-enhanced CT. Now, again, this homogeneous is always a tricky thing. I think sometimes things look more homogeneous on a non-contrast scan than contrast-enhanced, where you have very variable enhancement. So, again, it's a good rule, but like every rule, it's not going to be perfect. And so it's that small percent of cases. And if you look at their conclusion, and I'll just read you their conclusion again, papillary renal cells rarely, both subjectively homogeneous and low attenuation, measuring under 20 or under 30 on venous phase. But it can happen, just something to be aware about. So if you're uncertain, let's say you just weren't positive what to do, you could get another study, an MR, ultrasound, maybe that'll help, maybe that won't help, or you simply can get a follow-up, and probably 6 to 12 months might be the logical follow-up. So that's a good thing. Now, we've also made comments before about how the appearance on CT of a vascular renal mass can be used as a way of predicting response to tyrosine kinase inhibitors. And there's an article last month by Young, and I'll read a statement. In clear cell renal cell carcinomas, the gross appearance of intratumoral vascularity on CT was associated with a higher CAIX score, which is a prognostically significant molecular marker. Current assessment of CAIX scores requires path tissue sampling and immunohistochemical analysis. A non-invasive biomarker that may help predict CAIX scores would be of great clinical help. So you're basically saying, in other words, is that CT may be a thing that can replace these pathologic tests as predicting. Now, you could see that the big thing, of course, really is predicting response and outcomes. This carbonic anhydrase 9, CAIX, is a prognostic significant molecular biomarker for clear cell renal cell carcinomas. There's a numbering system, score between 0 and 300. The patients with scores under 100 are the ones that typically have aggressive tumors that spread or have spread already. Patients without lymphatic spread have a score of 200 to 300, whereas most patients' lymphatic was under 200 and is down to as low as 0. So the CIX score is a way of predicting, and the way you determine it is the gross appearance of intratumoral vascularity was present in almost 80% of clear cells with a score of 200 to 300, compared to 60% with a score of under 200. So again, vascularity is a very good prediction. One of the things we comment on is we do multi-phase, we always do arterial. The reason we do arterial, that's the best way of looking at the vascularity. And when you do things and you sum up the process, it works out very, very nicely. So that's a really good way of doing it. And it's a really good article. Again, it brings us back to the point that we've been speaking about, how it's very important to recognize how much information there is on a CT scan. Third thing I'll speak about is cinematic rendering, and it's probably easy to show you than to speak about. We have 3 lectures coming up over the next few weeks on cinematic rendering. There's a really good article by Steve Rowe in Renal Pathology speaking about how cinematic rendering is ideal across a range of applications. And in this article, he showed a number of different applications. He showed evaluation of the renal arteries for fibromuscular dysplasia or renal artery aneurysms. He showed it as a way of looking at the vasculature in a patient with suspected UPJ and being able to recognize the accessory vessels. Spoke about it in terms of staging tumor, spoke about it in terms of being a way of transferring information from the referring physician to the patient. Again, this whole idea about surgical planning becomes very, very important. And the ability to be able to accentuate within texture mapping different features of tumors. And remember, 2 minutes ago, I spoke about looking at those difficult cases, whether it's 20 being tumor or non-tumor. And with texture mapping, I think it's much easier to tell what's fluid and what's not. So I believe that one thing we will do with cinematic is do a lot more texture mapping. And I've seen this with pancreatic cancers and neuroendocrine tumors versus cysts, that we can look at the texture and predict whether the process is benign or malignant. And that's going to be very, very important. So I think that's a really important application. And I'll read you the quote. Cinematic rendering allows for a new level of anatomic detail with 3D CT visualization. The role of cinematic rendering in renal pathology has yet to be thoroughly explored, although the potential suggested by the photorealism of the figures in this review indicate that further study will be warranted. Ultimately, studies that explore the utility of cinematic rendering in a range of applications are needed to establish this technique. Again, we've had a lot of experience doing that. It's very hard to measure. I think one of the things that we drive ourselves crazy is if I show you cinematic rendering and ask the surgeon is better than what the information than before, they'll always say yes, because something new and shiny, regardless of how good it is, always looks better. And so 100% of the time it's better, but you need to figure out ways of basically testing them without the information, testing them with the information. We did that way back when we first started doing 3D and acetabular fractures, but now there's so much more information that we provide, it's hard to show that incremental change and surely measure it. The surgeons like it, they order it, but that incremental change, I think, is very, very hard for us to do. Now, a fourth paper I read was by Vanderpoel, and they were answering a simple question, looking at vascular renal tumors can metastasize, and one place they go is pancreas. Now, if you looked at just the pancreas and you have a solitary lesion, and we've shown this before, that solitary mets to the pancreas look identical to neuroendocrine tumors. The question was, can you use CT as a way of distinguishing neuroendocrine versus metastasis? Well, the first thing, obviously, most patients with metastasis, if it's coming from a renal cell, they've had a nephrectomy. Remember, pancreatic mets occur 10 to 15 years after initial presentation. So you will have had this knowledge on the scan. You see the kidney's missing, you're saying it's a neuroendocrine tumor. But sometimes, you have a solitary lesion. It may not be so simple. Now with mets also, they're more commonly multiple. So if you see multiple lesions in a vascular and a renal cell patient, the odds are it's going to be metastasis. Isn't that common to see multiple neuroendocrine tumors in anybody, but surely in that patient? And they also said, and here's one of the quotes, compared to pancreatic renal cell carcinoma metastasis, and that's clear cell renal cell, neuroendocrine tumors are larger, more frequently solitary, contain calcification, show main pancreatic duct dilatation, and are subjectively and quantitatively more heterogeneous. So I think one of the things is calcifications. Neuroendocrine tumors commonly calcify, mets don't. Mets obstruct the duct. Neuroendocrine tumors typically don't, but they indeed can. The size thing is kind of variable. If you have a giant mass, it's probably going to be a neuroendocrine tumor, but that alone is kind of not exactly perfect for me. Now, one of the things they did was using radiomics as a way of predicting, and we've been looking at that as well. And they looked at only one feature, entropy, and they said that there was a difference between the entropy between neuroendocrine tumors and adenocarcinoma metastasis from the kidney. So their feeling was that that would prove to be very helpful. And I think that makes a lot of sense. You have all of these different bits of information, and perhaps that's going to be helpful. And just one of the quotes from their article, with respect to texture analysis features, entropy was significantly higher in neuroendocrine tumors compared to renal cell metastasis, with a trend toward a higher level of kurtosis and skewness, although the difference in the two latter features did not reach statistical difference between the two groups. So it can be helpful. I think their work was, okay on that, but they probably needed to do more. So I think that most of the time I don't have much of a problem saying what's met versus neuroendocrine. The truth of the matter is the solitary lesion they're taking out no matter what. And if you have multiple lesions, I know it's going to be metastatic. So I think we could do okay there. It's a good paper to read. It's in abdominal imaging and it's in press. So it's, again, something that is worthwhile, again, thinking about how we're taking CT from just how we do things typically to now to the radiomics, to the texture mapping, to the 3D analysis. And their conclusion, our study demonstrates that subjective imaging features and quantitative texture analysis may differentiate neuroendocrine tumors from pancreatic renal cell metastasis, tumor calcification, solitary masses, and main pancreatic duct dilatation were specific features for neuroendocrine tumor, but lack sensitivity, whereas the quantitative texture analysis feature entropy improved sensitivity for diagnosis with moderate overall accuracy. So again, we're learning how to do more, and indeed that's going to be exciting. And the last article, we're running out of time. I read this one last night. This is an article by Kosick, just published in AJR, Radiogenomics and clear cell renal cell, machine learning, high dimension, quantitative CT texture analysis predicting the PBRM1 mutation. Again, I'll read you the objective of the study. Purpose of the study is to evaluate the potential for machine learning based high dimensional quantitative CT analysis in predicting the mutation status of the gene encoding the protein PBRM1 in patients with clear cell. And so one of the things they were able to show is you can do that. And I'll tell you, and I'll skip to their conclusions. Machine learning based high dimensional QCTTA is a feasible potential method for predicting the mutation status in patients with clear cell. Nonetheless, more studies with more labeled data are necessary for further validation and improvement of the method for clinical use. We hope that the present study will provide a basis for new research. Again, taking you away from just thinking about CT as arterial phase, venous phase delayed, multiplanar 3D. Now it's non-contrast arterial venous delayed, coronals, sagittals, 3D volume rendering, 3D MIP, 3D cinematic, and then post-processing of the post-process data analysis, looking at many of these different things to predict the genetics of the tumor and the response to chemotherapy, radiation therapy, or survival. So I think it's very exciting. And again, radiologists need to be paying attention to the space because it's not going to be enough. I think we're going to be expected to get this information, create this information, and interact with this information. It's going to change all the staging studies. It's really going to be a titanical change. It's not going to be small. It may take a while to happen, but I think it's going to be a rocket. So with that, if anyone has any questions besides John Biachino, who's saying hello from Body CT, I'll be happy to answer them. If not, we use up our time. As I mentioned, this was kind of a teaser on this topic, and I'll be coming back with lectures specifically. I'm working on it right now. And, as one of the things at CTisus we typically like to say is that as things change, we like to change as well. So we are constantly trying to update the material and provide new information for you. So if you missed it, hey, Mark DePaul has just joined. So Mark, if you just joined, you can go back in about 1 minute and watch the tape over. So if anyone has any questions, they come up with questions, which I don't see now, just feel free to jot it down, email us, go to our new Ask the Fish, whatever you want to do, and I'll be happy to answer the questions if I'm able to do that. And with that, have a great day. Bye.